Everybody Poops. That was, you know, a book. If you've ever read it, it's a great book for kids, but it should be for adults too. So again, these are topics that we're all dealing with. And I think when you see, I'm going to throw out some statistics at you, you'll just see how common it is. So with that being said, let me share my screen with you and we'll get started on the presentation. Okay. So here we go. And we're going to just play the slideshow from the beginning. Okay, guys, so welcome to Adore Your Pelvic Floor. Again, we're going to get to know our pelvic floor muscles first and foremost, because got to know where they are before we use them. We're going to talk about types of urinary incontinence. And again, there are lots of different things that can go wrong with our pelvic floor, but this is today's topic. There are other things as well, including you can have pain with sex, or again, pelvic floor pain or tailbone pain, but those can all be discussed at another time too. So if anybody has any questions, you can bring it up. But today's urinary incontinence, leaking, and how physical therapy can help. So again, today we're going to go over, again, the pelvic floor and core anatomy, learn about the different types of urinary incontinence, learn about the different populations at risk, learn how to access your pelvic floor muscles, and then some basic exercises and treatments you can do. And of course, then learn how pelvic floor PT and other treatments can help with it. Disclaimer, of course, even though some of you, I do know, this is not necessarily going to replace medical advice. So again, this is for general guidance only. And again, please always seek advice from your medical professional before starting any program. Okay, so let's dive right in. So the pelvic floor muscles, how many of you are actually familiar with like where they are or what they do or how to do a Kegel? Okay, Mom, great. Some people, Jackie's like maybe from the people I can see on screen. So it's actually cool. There's 3 layers of these muscles. So we tend to think of them as a group, but there's actually 3 different layers. You have your superficial muscles, your deep perineal pouch, and then your pelvic floor diaphragm. So we're going to kind of go over that anatomy and how that helps us be continent and support us. So this is layer 1, which is called the superficial perineal pouch. And I put a male pelvic floor on here as well too, because you can see we're actually pretty similar, by the way. They have some extra appendages, but for the most part, the muscles are the same. So this first layer, as you can see, wraps around, this is the vagina and then the urethra. And it does wrap around here and it helps to kind of contract everything to keep us continent here. The next layer is called the deep perineal pouch, and this is where we do differ from males a little bit. So men just have this, the deep transverse perineal muscle, and then the external anal sphincter. You can see for females, we have a couple other muscles in this layer too that really help to keep us continent and also wrap around the vagina. So that all helps with, this person too, that all helps us with our pelvic floor, and when we're doing our Kegels, these are all the muscles that we're actually contracting. And then finally, layer 3, this is only a female pelvis, but again, the male doesn't look so much different. They obviously just don't have a vagina. But again, this is the deep layer, and these are the muscles that really help to support us. So they support all of our organs. They support us from below, and you can see they kind of do wrap around from the front here. This is the front of the pelvis to the back, and just hold everything kind of up and in place. So when we usually think of the pelvic floor or Kegels, these are the muscles that we're thinking about. Okay, and again, muscles wouldn't act without nerves. So the neural input to the pelvic floor is super important. You have both a somatic nervous system and an autonomic. And if this is taking somebody back to biology and you're like, oh my God, what is she talking about? We're not gonna go into too much detail, but just know that the somatic, that's your nervous system that you can activate. So that's the one when you're doing your Kegels and you're contracting, those are the muscles, that's the nerves that you're working with here. And then we have our autonomic nervous system, which again is made up of your, kind of like it's in the background, it's automatic, you're not thinking about it, but it's working for you all the time. So you have your parasympathetic and your sympathetic. So if anybody practices meditation or anything like that, that's kind of turning on that parasympathetic, rest or digest, sometimes we call it, versus fight or flight. But they work together for the pelvic floor to help with bladder storage, and then also with emptying the bladder, so really important. And then finally, I thought this was a really cool picture. So cutaneous, this is like the innervation to your skin. So you can see all of these nerves start from, most of them, the lumbar spine, and they come around down. Now, for those of you who've had hysterectomies or any pelvic floor kind of surgeries or any surgeries in this region, including hernia surgeries, you can see right where the nerves are. So sometimes these nerves can be affected by those types of surgeries or scar tissue in the area, even childbirth. So sometimes people may have numbness or tingling here. And most of the time when we're having issues down our legs, we always say, oh, it's sciatica, like I have sciatica. We hear that all the time in PT, but sometimes it's actually these nerves too. And if you have any back pain, you can see how that could also affect not only these nerves, but your pelvic floor as well. Okay, so getting into the pelvic floor function, we call it the 5 S's. So again, I love this picture because you can see the pelvic floor from the side. That red sling is holding all of us up from below. It does connect from the spine to the pubic bone in front. And you can see your bladder, your uterus, and the bowel. Everything has to exit the pelvic floor. So they really have to be strong to hold us up. And above that is going to be your intestines. So again, just a lot of pressure downwards that these muscles are working hard for us for. So of course, the first function is support. Again, and the other one is sphincteric, which again, that's the sphincters that are opening and closing. Sexual, again, it maintains erections and it assists with blood flow to those muscles during that time. Stability, as you can see, it's part of the whole core system, and we'll see that a little bit further on as well. And then sump pump. So I had to learn, I was like, they're just being fancy to try to keep everything to S's, but I guess it is a pump in the basement and it helps to pump fluid up. And that's exactly what this is used for. For those of you who have ever had cancer treatments, you've probably heard of lymphedema or lymphatic issues. So again, with the pelvic floor, it does act as a pump to help pump lymphatic fluid. Okay, so the pelvic floor is the core. So if anybody here is doing Pilates or yoga or exercise classes and you've always been taught your core, a lot of times we just think of the core as like where everybody's like stomach muscles or back muscles. But this is what in PT, especially, we think of when we think of the core. So it's almost like this bottle. And the top part is the diaphragm for breathing. So again, when you come to pelvic floor PT or really any exercise, breathing is super, super important. And then you can see that the pelvic floor is below and it helps to support us and it kind of mimics that diaphragm. Through the center, you have your deep ab muscles. This is called the transversus abdominis, which wraps around you like a weight belt. And then you have the multifidi, which are these little muscles that go up and support the spine. So they should all be working together to help stabilize your core and your trunk region. So with that being said, again, I love this picture too, because it kind of shows how they work together. Oh, bummer. It was supposed to move, but it's not. But you guys are going to move instead. So what you're going to do is, again, you can do this in sitting or standing, whatever feels better. But I want you all to be able to feel these muscles so that you are comfortable knowing where they are and how to explore them. So I'm going to stand just so you can see my full body. But the diaphragm, again, you're going to hug kind of the bottom of your rib cage area. And go ahead, yeah, everybody here, take a nice inhale in. So as you inhale, you should kind of feel your hands expanding away from your body. And then exhale through the mouth. Nice, Carol. And then again, inhale, expand. And exhale, release. So that's accessing your diaphragm. Now to access the diaphragm with the pelvic floor, because they do move together, as you inhale, the pelvic floor should drop down because the diaphragm is dropping down. And as you exhale, the pelvic floor should come back up. So if you're sitting, you should be able to feel that a little bit easier as you inhale into the ribcage. Now turn your attention downwards to the pelvic floor, kind of in between your two sits bones. So those two bony prominences in your body. Inhale here and expand. And exhale, release. And you may feel a little bit of movement, like the tailbone opening up a little bit, the two sits bones expanding a little bit. So that's your pelvic floor moving with your diaphragm. Inhale again here through the nose. And exhale through the mouth. So when we're first getting patients to PT, regardless of what pelvic floor issue they have, we often take a look at breath first. A lot of people are chest breathers. So again, if you're breathing into here, you're getting a shallow breath. You're not letting your pelvic floor move. And again, that comes a lot with the stress of our daily lives too. So I definitely recommend you look at how you're breathing every day. Let's activate our deep ab muscles now, that transverse abdominis. So to do that, you can put your hands on your belly, kind of around your hip bones. Bring it inwards there. Oh, there it goes. Now it's moving. So that's how you should have moved, hopefully. Go ahead here and you can pretend like you got punched in the stomach. So just make like oof noise. And you should feel kind of bunching underneath your hands as you did that. So again, like oof, or again, almost like you're bringing your navel into your back. Sometimes we say that. That's more of like a hollow move, but that's going to be your deep transverse abdominis. And then finally, to activate the pelvic floor muscles below, of course, that would be a Kegel. So again, in sitting, there's a couple of different ways to activate it. What you can do is, again, a lot of times we give the cue of stopping the flow of urine. So again, you can think about accessing those muscles or holding in passing gas and see if you feel more of a lift to the muscles now too. Good. All right, any questions on how to access your pelvic floor or your core in general? Or everybody good? Right, I don't see anything, so we're going to continue on. Okay, so now we're going to talk about, again, urinary incontinence, which is what we're here for today. So before we talk about incontinence, let's talk about what continence means. So again, this is going to be the voluntary control of your bowel and bladder function. It requires the intact nervous system. As you could see from the previous slides, again, there's a lot of nerves that go into play to help keep us continent. And again, a coordination between the brain, bladder, and pelvic floor muscles. So they all work together. And actually, I'm going to bring up a good point here. A lot of people have said, oh, when I go to the bathroom to pee, should I do Kegels? Because that's what we were told sometimes growing up, like, oh, that's the way we strengthen our Kegel muscles or our pelvic floor muscles. I'm going to ask you right now, if you're doing that, to stop. So you have this coordinated, complex system in your body that's always working for you. When you are going to the bathroom, which we'll see on the next, nope, not next slide, but coming up, the bladder muscle has to contract. During that time, the pelvic floor muscle is relaxing. So please let your pelvic floor muscles relax when you're going pee and let the bladder muscle contract. When you contract those pelvic floor muscles, that disrupts that loop, that system. So even though it's the cue to, like, again, pretend like you're stopping the flow of urine, when you're going to the bathroom, please let yourself go to the bathroom. I think that messes up a lot of people, actually. So fun facts about your bladder, it can hold about half a liter of fluid. It fills at about 15 drops a minute. It fills every 2 to 4 hours. So that's when we say normal urinary frequency. So the amount of time you should be going to the bathroom should be about every 2 to 4 hours. If you're somebody who goes a lot more than that, like you've been called a nervous peer, you have like a nervous bladder, know that physical therapy can help with that. And that's actually not what we want to see. We don't want to see you going to the bathroom every hour, every half hour. You first feel the desire to void at about 150 to 200 milliliters. So that's about 5 to 8 ounces. And again, the bladder, so it's about 25% of when the bladder is full. So when that happens, the bladder will send a signal to your brain saying, hey, I gotta go to the bathroom. And your brain will say, sorry, I'm in a meeting. Sorry, I'm on a Zoom call. Like, I can't go right now. And so then the bladder says, okay, that's fine, and goes back to filling. Sometimes when people have that urinary urgency, you have trained your bladder has trained your brain almost to respond to that first urge. So it's like, hey, I gotta go to the bathroom. And then your brain's like, okay, let's go. And now you're going all the time. And now your bladder has become like a bratty child, kind of directing your brain versus the opposite. So again, we help people with that too. When you do go to the bathroom, there's always something called post-void residual, which means there's always some fluid left in your bladder. So the same when your heart beats, there's always some blood left in it too. The same with the bladder. So when people are like, oh, I need to fully empty my bladder, know that you're always going to have some liquid in there. Okay, so this is, again, normal urination, which you guys are doing all the time. You never thought you'd have to think about it, but this is the actual process. So again, you do want to sit on the toilet. A lot of times we hover, and again, you don't want to hover. You do want to actually let yourself sit. When you hover, that actually keeps those pelvic floor muscles on. And remember, we do want to be able to relax them. So the toilet seat is not as dirty as most of us think it is. Even during COVID times, probably not. So, but if you are really nervous, put down some paper or anything like that. So again, you sit on the toilet, then you want to relax your pelvic floor muscle. And then again, the bladder, that detrusor muscle, is going to contract for you. So again, there really is no need to push or strain during this time as well. If you're somebody who feels like you're always in a rush to go to the bathroom and you have to like push it all out, again, let yourself sit on the toilet, see if that helps to relax you a little bit more. Or again, if you feel like you're pushing or straining just because the urine is not flowing correctly anymore, that again can definitely be something to discuss with your urologist, your OB, and then also a pelvic floor PT. Okay, so types of urinary incontinence. These are the major types. There's urge urinary incontinence, which is again the loss of urine accompanied by a strong desire to void. So I talked about that a little bit before. If you're somebody who's going more than 2 hours and you're that person who knows where all the bathroom exits are on the freeway, you get to a mall or like a public place, maybe not again right now because of the pandemic, but like you just knew where all the exits are, or you sit on the aisle seat of anything because you don't want to bug people if you're going to the bathroom. And then you leak on the way there when you feel that urge, that would be classified as urge urinary incontinence. Stress urinary incontinence is when the involuntary loss of urine with exertion. So this is the laughing, coughing, you're doing like, jump rope or something and you leak. If you're walking and you leak, if you're playing with your kids and you're leaking, that's considered stress urinary incontinence. Then you have mixed, which is a combination of both stress and urge. And we see that a lot too. So it's not uncommon to see both of those at the same time. There's also overflow, which is the involuntary loss of urine due to an overfilled bladder. This happens more in males than females. A lot of times the cause is, again, for men, enlarged prostate. So again, it's something that's blocking the urine from coming out. There's also transient incontinence, which is when the urine leakage happens for a short time. So again, just like sometimes when you're ill, some of the medication can actually make you incontinent, or again, you're too sick and so you lose urine a little bit, or again, during pregnancy too, but then it goes away after pregnancy. And then we also have functional incontinence, which means someone who can't go to the bathroom quickly enough due to like a physical or mental impairment. So this might be somebody who, again, has really bad hips and needs a walker, and it's hard for them to then get out of bed and make it to the bathroom. The majority of the research and the majority of what we see in the clinic are these first two. So when I talk about the studies and everything coming up and also how PT can help, these are the main two that we're looking at. I love this picture. I thought this was like a good graphic of kind of the three main types that we see and the effect on the bladder and the muscles. You can see with stress incontinence, that is when they're saying it's a relaxed pelvic floor. Again, this is kind of generic. And then again, there's increased pressure from above. So again, either you're coughing, you're laughing, you're sneezing, you're jumping. This is urge when again, there's oversensitivity. Again, there's something wrong with the nerves there too. So they may be causing the bladder to spasm a little bit more. I would also argue a lot of times we see people with urge incontinence who actually have tighter pelvic floor muscles, because the pelvic floor muscles can actually refer to the bladder and make you feel like you have to go to the bathroom. And so that's what we look at as pelvic floor fatigue. All right, so the prevalence, again, any of the research or any of the statistics that is done is mainly done on stress. That's the one, again, where you're jumping, you're running, and you're leaking urine. Again, as you can see, the research sucks. So it varies widely from 2 to 60%. For males post-prostatectomy, it can be 2.5 to 87%. But over 33 million Americans suffer from some type of urinary incontinence or bladder condition. And again, we oftentimes think of this as like an older problem after menopause, after pregnancy. But this was a really interesting survey they did on 291 elite female athletes. And look at this age, the mean age is 22.8 years. 43% of them surveyed experienced urine loss during sports. Again, gymnasts being the highest. And then also they have, you can see ballet is 43%, volleyball 30%, basketball 17%, and 42% surveyed experienced urine loss in daily life. So again, are these people who have weak pelvic floors that need Kegels? Probably not. Most of them, they have higher and tighter pelvic floor muscles. And again, they can't withstand the pressure when they're doing their jumps or their hard workouts. Continuing on with this, again, with pregnancy-related urinary incontinence, the last trimester, about half of prima pares, that's women who've never given birth before, that's their first time, have incontinence. 85% of women who've given birth multiple times. That's a huge number. And then postpartum, 92% of those incontinent at 12 weeks after giving birth were still incontinent 5 years later. Let's see, age-related, you can see it does increase. So again, 18 to 40 is about 16%, and these are all female numbers. 41 to 64, 33%, and if or if you're 65, about 55% of people have some form of urinary incontinence. So again, a lot of people come to our clinic thinking they're really embarrassed about this problem or that it's an issue that only they have. But know that you're actually probably in the majority. It's just that we don't talk about this like other stuff. So, you know, if like your elbow was hurting, you could tell your friends like, oh my God, my elbow hurts. Like, and your friends are like, I used this cream. I did this for it. I saw this person. But a lot of times we don't tend to talk about these issues. And then again, 200 women between the ages of 17 and 45 experiencing lower back pain, 78% reported urinary incontinence as well. So again, you can see it's not just a pelvic floor issue. Again, in physical therapy, we do try to screen for this. So again, if people are having back pain, anything like that, we tend to look at the whole body. And again, incontinence is one of the most common reasons for being admitted into assisted living. So again, this is a national issue that we should all be talking about and doing something about. Okay, so some of the causes and risk factors, and I think you can all figure out why these would be issues. Age, as we saw on the other slide, pregnancy and childbirth can all increase it. And again, a lot of times that is because there's just increased stress on the pelvic floor. Menopause, I wanted to kind of break and talk about this a little bit more here as well. So when we say menopause, we don't just mean, yes, there's the natural aging menopause too, but I know a lot of you on here are either you've had like not chemo induced, but like induced menopause because of medications you're taking too. So again, people on aromatase inhibitors, again, that blocks your body from making estrogen in it. So again, usually postmenopausal women will get that for their breast cancer treatment. And again, some men also get hormone blocking treatments as well. And then usually younger people, so if you're premenopause age, you'll usually get tamoxifen as well, which will also block estrogen from being recepted into your body. So it doesn't necessarily have to do with your age menopause. It can also be caused by certain medications you're taking too. And estrogen does help to plump the urethra and vaginal tissues. All those pelvic floor muscles that we saw, they really do respond to estrogen. So that is one of the reasons why you can see urinary incontinence with that. Again, pelvic floor and lower extremity surgery, including hip replacement. Yeah. The internet's not connected. Sorry, I heard something in the background. So again, if you have like a hip replacement, because they are going through muscles that surround the pelvic floor, that can lead to weakness in the area too, or instability there as well. And of course, the hysterectomy can create scar tissue in the region, so it can fall on the bladder. Also, you don't have the support from the uterus anymore, so then the bladder tends to sit a little bit lower, and we can see things like prolapse. Obesity too, usually again, because it's thought that if you're very heavy, again, there's just more pressure downwards on those muscles, so they have to work a little bit harder. Any pelvic floor muscle dysfunction, of course, that they can't contract, that they can't hold for you. And then also medications that affect the bladder. So again, if you're on anything like diuretics, I don't have to tell you, you're going to the bathroom all the time. So again, that can affect, like, can you get there in time? Are your muscles strong enough to hold? But other things can also affect it. So even if you're on like antihistamine, calcium channel blockers like Procardia, a lot of these actually calm the bladder. So it actually makes it, you retain urine a little bit more. So keep that in mind too for your medication. Okay, so with that being said, what can we do for treatment? What is the magic bullet, right? That can we just take a pill and get better? It depends. We hate to say this in PT, but everybody's body is so different. And so that's why we really have to examine people. That's why, we like to see how you're moving, the whole thing, because there are an array of treatments. So you've probably been taught to do Kegels. You're like, oh yeah, we can just do their Kegels. We'll get stronger. It'll be so much fun. And Kegels have definitely been shown to help with urinary incontinence. There's really good studies to back them up. However, findings show that 25 to 40% of women will Kegel incorrectly. So if you're just told by your doctor to do a Kegel, 25 to 40% of people are doing them wrong. And for some types of urinary incontinence, they actually may be contraindicated. So again, if you go back to those gymnasts, those runners and basketball players, they probably don't need to do Kegels. They probably actually have, again, strong muscles. They probably need to learn how to release them. Okay, so for sample treatment, there are different routes you can take for urinary incontinence. And again, it depends on if you have stress urinary incontinence, urge urinary incontinence, etc. These are things that MDs can do and things pelvic floor PTs can do as well. It's not usually one or the other. It's usually collaborative and a combination. But we'll go through some of them. I'm not going to speak too much of the MD one again because I don't have the authority to do these. So I'll just take you through them really briefly. There is something called the Mona Lisa laser or Mona Lisa touch. And it is basically a laser, a fractionated carbon dioxide laser. And you do usually they say about 3 procedures up to 18 weeks. And what it does is the laser helps to stimulate collagen in the pelvic floor. So it's nice for people who are usually postmenopausal, need to have the tissue plumped up again. And it's hormone free. So again, people who are worried about hormones and issues like that, that's a great option for you too. It's usually not covered by insurance, unfortunately. Each session can run about $800 to $4,500, depending on your doctor, where you go to, and what they decide for you. There's also some nerve stimulation. So this is for overactive bladder. And this is an example of one. This is called PTNS, or percutaneous tibial nerve stimulation. And what they do is they actually attach 2 small needle electrodes into a nerve at your leg called the tibial nerve. And it sends signals up to your sacrum and it helps to relax that area. So those are for people who have overactive bladder. Again, you're going to the bathroom all the time. You have the urge incontinence, things like that. This procedure is covered by Medicare and other insurances are variable. Medications I kind of didn't talk about, but again, that's more for your doctor, but just know that they do have medications to help increase flow or decrease urge. There's also estrogen cream that you can use vaginally as a suppository, which helps pump up the tissue. These are pessaries, so that was going to be next on the list. For a lot of times for people who have stress urinary incontinence, again, the incontinence with exercise, you can get fitted by your urogynecologist, sometimes a regular urologist or gynecologist as well. And it kind of helps to hold everything in place there too. So if you ever wore like a diaphragm, as birth control or anything like that, kind of works the same way. And it is removable, but it will help to support you. There's also surgery, which is usually a last minute, or not last minute, like a final thing if you needed it. They do have urethral bulking. They also have slings and bladder neck procedures too, if just nothing else is working for you. In pelvic floor PT, we can do a lot of stuff as well. So there are bladder retraining and delay tactics that we teach people. Again, if you're somebody who's going all of the time, that breathing that we worked on, that diaphragmatic breathing is a big way to do it. There's also exercises you can do. So again, we've talked about Kegels, but we give you so much more too, because we want to look at functionally what you're doing. So if you're losing your sit to stand, just doing a Kegel will not be enough. There's a lot of exercises we can give you as well. And again, we can make it harder. So again, doing it on your back, on your side, different positions, and going from there. We also, again, look at posture. That's a huge role. So again, everybody's sitting right now. So go ahead and sit in your chair again. Go ahead and bend forward. So give yourself that bad posture of like that slumped position and try to do a Kegel here. And then go ahead and sit back up again, nice and tall. And now try to access your pelvic floor muscles again. So do the Kegel there. Hopefully you should feel a lot better in that sitting upright position. And they have found, again, and we're all guilty of this, that forward, we're on the computer all day. So it actually puts our pelvic floor muscles at an inefficient position. So again, we definitely start here too with people and get you in the best position to do your exercises. We can also do manual work for soft tissue restrictions. So again, if you have scars, like scar tissue on your abdomen, or again, for people who pelvic floor muscles are on the tighter side and need to be relaxed, we can do manual work for that too and show you how to do it as well. And then they have biofeedback, including Kegel exercisers. And these are actually really fun. Some of you may have seen commercials for them or seen them on your Instagram feed or anything. This is an example of one. This is called the PeriFit. And what it does is it basically is a device and you would put it internally, vaginally. And most of them now connect to an app. So you can have an app on your phone that it connects. And as you squeeze the PeriFit, you can see your contractions on screen. So that's what we call biofeedback devices. Some of them have vibration and some of them don't, but it's retraining your muscles that way. The important thing, and again, these are accessible online. You can honestly just go anywhere and buy them. But what I would recommend is, again, see a pelvic floor PT first to know if that is something that you need or not.
Hey, Mae, we had a question. What
What's up?
about the V-Fit? There's
The
another.
V-Fit. Oh, I see. Pessary, good for prolapse. Oh, yes. Yes, a pessary is great for prolapse. That's actually what it's used for. The V-Fit, I'm not familiar with. Is it similar to the, I mean, there's so many out there. There's like the LV, there's this one, there's the Attain. Like, if I don't know if it's a biofeedback device or not. I can look it up. But yes, a pessary is absolutely made for prolapse. Let's see, V-Fit Plus. Intimate wellness solutions for menopause. Interesting. I would have to rejuvenate with our high-tech vaginal wellness products. Cool. I will look more into that, to be honest with you. Red light devices. Okay, if it's a laser, that's pretty interesting. Stimulates tissue and encourages blood flow. To be honest with you, I haven't heard too much about this one. But red light therapy has been shown to, again, help with anti-inflammatory properties and stuff like that. So it's not necessarily, I don't see why it would be a bad thing. But yeah, that's a good question, Carol. I'll look more into it. Okay. Okay, and then again, how can physical therapy help? So again, a lot of people come to our clinic and the first time they have like no idea what to expect from pelvic floor PT. They're like, you want me to do what? So I just thought I'd share today to make everybody a lot less, or more calm when you come in. Again, we do go over your medical history because, as you can see, there's so many factors that could be leading to incontinence. We will ask about diet, water intake, bowel habits, bladder habits, pregnancy history, surgical history, all that fun stuff. We want to get to know you as a person. Then we're going to look again at your whole posture. So it's not like we're just like, oh, you're here for incontinence, let's check out your pelvic floor. Like you saw from other slides, posture is really important. How you're moving, what your hip range of motion is, what your hip muscle strength is, all of that is super, super important and could affect your plan of care. Then we will evaluate the pelvic floor muscles. So how do we do that? It's not like an OB visit where you would use a speculum or anything like that. You're usually on the table. And again, we would use a gloved finger and we check the layers. So we do go layer by layer. And we're gonna see if you can contract, relax, how long you can do it for. Can you bulge, any tightness? Are any of the muscles, do they have trigger points that are, and you're like, ooh, that's a trigger point. I feel like I have to go to the bathroom. So we're gonna look at all of that. Then we're going to come up with a plan of care based on our findings and your goals as well. So just know that, again, it's not like a one size fits all model. We really do try to, tailor it to your needs and your body and what's going on. Okay, so again, finding your pelvic floor muscles. We kind of did the Kegel already, but if you did that and you were like, Mae, I still couldn't find my muscle. Like, that's okay. I'm going to give you some other techniques right now, and hopefully you'll find them this way too. So again, everybody can do this in sitting or standing, whatever feels better for you. And again, we already went over the cue of stopping the flow of urine, holding in gas or bowels. But another cue is this one, which this nifty, thank God this picture working. We call it the elevator. So again, you want to think about starting from the pelvic floor, that's the ground floor. And again, you're going to take an elevator. So again, you start from the bottom and lift it up through the pelvic floor, up through the lower abs, up towards the rib cage. And that is kind of the way we also want to activate the pelvic floor. Because a lot of times what happens is people are just squeezing, especially if you've gone to like a Pilates class or something and they talk about, the abs or contracting the abs. It's a lot of it is just tightening here. But think about it. If you're just tightening that center, and not tightening the bottom, where is all that pressure going? To your pelvic floor, right? So that's when you can see things like leaking and stuff like that too. So a lot of times we get people where their abs are so super strong and they're just activating from there, but then all that pressure is going downwards. So we've definitely seen that as well. This is a fun one, actually. Let's do it too. So your feet are going to go on the ground. And go ahead and curl your toes too. So go ahead, if you curl your toes under, sometimes that can get a connection to your pelvic floor as well. Because in our brain has an image of our body, and the toes are actually right next to your genitals in the brain. So sometimes we use this overflow cue as a way to strengthen the muscles. If you're just like, I have no connection to my pelvic floor, we can do that instead. There's also vocal cues we can give, because again, just the same thing. This is all connected in this region. So again, you can try a high humming, like a, and you don't have to do it. You're on mute. You guys can do it. So you can try that, and that should also help lift your pelvic floor muscle. Versus a low hum, like a that should actually release your pelvic floor muscle. So oftentimes for people who have urinary hesitancy, like if you're trying to go to the bathroom and you just can't get it out, if you try that low hum, that will help release your pelvic floor muscles. And of course, you can try different positions. So some parting tips and tricks before we leave. Again, these are just good for bowel and bladder health in general. Again, you want to try to go for, this is for urine, not for bowels, but go every 2 to 4 hours. And you want to do no just in case peeing. So if you're someone who's like, oh, I gotta run to the store right now, I just went to the bathroom, but I'm gonna go again just in case, we try to again eliminate that, because that ruins that whole bladder brain connection too, where you're, again, that bladder is the one calling all the shots versus your brain. Again, let yourself sit on the toilet, no hovering if you can. No straining as well. Again, let your muscles do the work that they're supposed to do for you. Again, avoiding constipation, because with constipation, you're pushing out a lot. That's going to create more pressure on the pelvic floor, especially if you have things like prolapse and stuff like that already. That's going to just add more pressure downwards. You want to be sure you're drinking enough water. A lot of times people who have the urinary frequency and are going to the bathroom a lot or have incontinence, nice Jackie drinking, a lot of people reach for the water when they say that. Yeah, you want to drink enough water, because again, a lot of people are like, well, if I don't drink water, I won't have to go, right? Wrong, because remember that the bladder is filling no matter what you're doing. So it's still filling, and it still is going to hold liquid for you as well. But the liquid may be, because you're not flushing it out with new water, it actually may irritate your bladder more. So again, make sure you're drinking enough water. How much is enough water? So we generally tend to rely on about body weight. So we want to say about half your body weight in ounces. A 100-pound person should be drinking about 50 ounces of fluid. That includes coffee, other things as well, but about 2/3 of that should come from water. You want to avoid bladder irritants if you do know, again, if you're somebody who's going all the time and has that urge. So what are bladder irritants? For people, it's all different, but the 3 that is research-based that we know about is coffee, alcohol, and carbonated beverages. So those are 3 that we know for sure are bladder irritants. Now, does that mean you can't drink coffee or anything like that? Absolutely. Like, I drink coffee every day, like, but just know that if you are drinking it, then you'll probably have to go more. Definitely you want to pee before and after sex to help avoid UTIs and other infections. And then, of course, if you have more questions, or you're just like, oh, I think I might fall into one of these categories, maybe I need a little bit more help, please see your MD and your pelvic floor PT as well. And that's that. So yeah, any questions? And again, for more info, this is our phone number here, our website, and then that's my personal email address too at work if you have any questions too. So I'll stop.
And if anyone else has or would like information about our office, definitely put that in when you sign in in the link that I sent over earlier.
Everybody all good? Any I know that sometimes this can be not a fun topic to discuss or like embarrassing, but we're all friends here now, so who you have any?
Thanks, Laura. I just sent in the sign-in link. So when you go ahead and sign in, you can put in if you're interested.
She may not have, if you put in the link before people come in, Sabrina, I think that they don't get to see the messages that were sent above.
Okay, thanks, no problem. I reposted it just in case for anyone else.
Okay, awesome. Yeah, but I hope you all feel more comfortable with your pelvic floor now and more comfortable being able to talk about it. I talk about it all day long to anyone who listens. So yeah, it's not an area we talk about that much, but as you can see from the numbers, almost over half of people are have an issue. So yeah. Oh, hi, Uni. Oh, really is like a welcome to Mae's life group. I love it.
Thank you, Mae. Good job. That was great.
Oh, thanks, Jackie.
This was awesome. Thanks, Mae.
Awesome.
Thank you, Mae. Thank
You're
you.
welcome. Yeah, and Carol,
Thank
I'll look more
you.
into that VFit. That actually looked really, there's so many products out there now too. So it's kind of like hard to navigate. And I would say we often find out the information from our patients because you got like, people are there, if you have the issue, you're the one researching literally like every product on the market. So yeah, that looks cool.
Thanks.
Okay.
Thanks, Mae. Bye. You did a great job.
Thanks,
Awesome.
Mom.
Thank you.
Okay. All right, guys. Have a good one.
You too.
Hey, Laura, I'll go ahead and send you a chat and you can send me your email so I can send over some information if you'd like. Just hang tight.
Mae?
Yes.
It's Abby.
Oh, hi.
I don't know if maybe people want to ask questions if you stop recording. Sometimes people feel
Well, I think most people are gone now.